necessary, but we want to keep it to be close, so you can just sit there and then afterwards need a spot, find a spot at the table.
Okay, there are still some places over here. Silence. Okay. Welcome everybody to this workshop about shared decision making. As you know from the introductions yesterday, shared decision making is a very important component of patient-centered care, and it's become more and more important also in the consultation that we have with our health professionals. So for that reason, we want to focus more now on the concept of shared decision making, how to implement this in clinical practice, and to look at the barriers and how we can overcome these barriers. And to lead us through the concepts, we have invited Stiggelbout. She's from the Netherlands. She's a professor of medical decision making and an expert in the field of shared decision making. And we are very honored and very pleased that you have been willing to participate in this workshop and to come over to Dublin. So thank you for that. I would also like to thank Christina Opava, who is representing the health professionals and who also is willing to moderate one of the working groups. My name is Maarten de Wit, and I am part of the working group that prepared this conference. So I don't want to spend more time on introducing Anna. We are really looking forward to hear what you know and want to share about shared decision making.
Thank you, Maarten, and thank you for inviting me over. I think this is really special. I've never been at a conference like this, and I had one workshop before, quite the same topic, and I think it's really exciting, and I'm happy that you are all here in this workshop. And I'm going to give a brief introduction on some of the theory concepts on shared decision making, because it's a term, of course, everybody uses it, every doctor thinks he or she does it. It's such a normal word, but we have sort of defined it and have steps, and if you see those, you realize it doesn't happen a lot yet. A little bit of history. It's been around since the early 70s already. I think Veitch was the first to use the term sharing decisions between doctors and patients. Because then you had, of course, this engineering, which we call the patients knowing, having the information, knowing what they want, and choosing themselves, versus doctors choosing for their patients without giving them much information. And in the middle, of course, the shared model. But what I quite like is the model by Emmanuel from '92. I give that to my medical students because I think it's really relevant still. They have, in the middle, they have two models, and a deliberative one is where you sort of have a really good treatment and you want to help patients realize that it's a good treatment. So you sort of steer the patients towards that treatment. Whereas the interpretive model, which is more of the non-directive counseling model, is where you really want to help the patients find out what's good for them. And I think the shared one is really about helping patients making decisions. And that also relates to the question, the types of decision making, because I think shared decision making is particularly relevant in situations where there's not one clear best treatment. There's so-called effective decisions where there's general consensus, 99% of patients and doctors will think this is the best option for the patient. Whereas the more preference-sensitive decisions is where the decision depends on subjective trade-offs. And then, of course, we have debates with clinicians who think that many of their decisions are effective, whereas hidden behind the guideline is some sort of subjective trade-off that the guideline committee has made and said, well, this one is worthwhile for patients, so we think as doctors that the benefits outweigh the harms, whereas patients might still think it's not true. So there's a discussion in the field of when are decisions preference sensitive and when are they effective, and I guess you as patients will probably think many decisions are preference sensitive that your rheumatologist might not think are so. So you have also two types of consultations then. For effective decisions, if doctor and patients quickly agree on what the best treatment is, it's mostly about implementation. Can you be adherent? Can you deal with the side effects? Can you comply with the scheme, whatever? Whereas in the preference-sensitive decisions, it's about helping patients figure out what's important to them and how to weigh benefits and harms. And shared decision-making, if you're a good communicator, you can do it in any situation. But I think for doctors who generally are not used to these types of consultation, I tend to stress it's the most important for shared consultations. If you're at the ER and someone comes in with a broken arm, you're generally not going to have big discussions on how to operate on that arm. And why is it so important? Because research consistently shows, and you probably know from your experience, that there's wide variation in preferences. Among patients, different preferences. Among doctors, also, it's not that all doctors think the same way about treatments, and between doctors and patients. And we know also from research that clinicians think they can predict what patients want, but generally they don't. They're not good at predicting how much information patients want. There's a general lack of information experienced by patients. They often don't have the right estimation of patient preferences for treatments and for the role in decision-making. Doctors often say patients won't have a role in decision-making. Well, that depends on the way you communicate with them. And if you do it the right way, they might say, yes, I do want to participate in this decision. So I've been talking now for a few minutes about shared decision-making, but what is it? Have you ever seen it? Have you ever experienced it? Who's sharing decisions with their doctors? This is probably not the best audience, of course. You're patient representatives, but you're not probably very representative for patients. Do you share with your doctor your decisions? With a physiotherapist? Okay. Nurses, physiotherapists, occupational therapists tend to be more sharing, true. Others? Anyone has a fantastic rheumatologist that always shares the decisions? No? Yes? You choose a doctor that does it. But most of you have experience with doctors that are not very good at this. Literature shows that it's not happening a lot. What do you think are essential elements? When do you think a decision is being shared? It's harder with a big room. We had a smaller room this morning. Yes?
Well, maybe if you offer some options and you are about to select between these options and you ask what do you prefer, what is important for you?
Major step, the offering of options, showing the patients that there are options to choose from, that there's not one best decision, but there's options, and that the opinion of the patient counts. That's the major first step that we always tell doctors to do. And in general, patients come in, the decision has either been made beforehand, or the doctor says, I'm going to discuss the treatment and the side effects with you, whatever. It's not clearly laying out of options and showing that there is a choice to be made. Other examples of things that should be in there in a shared process? We don't stop here. We do something else. Yes? Avoid the? Avoid the internet. Yeah, so the patient should avoid going to the internet. Yeah. Yeah. You drown on the internet. On the other hand, if your clinician tells you which pages to go to, the internet might empower you. So it's not all bad, the internet. Yeah. Yeah. Okay. Other? Yes? So active patient participation, patient as a partner. Look, where was it? In partnership. I'm just, for time, we don't have much time, so I'm skipping to the slide now. One of the things is that they're encouraged to consider the available options. So there should be options. Patients should be encouraged to be active and to weigh the benefits and harms, communicate their preferences, and help select the best treatment. This is Glyn Elwyn, is the major author in the field who's written hundreds of papers on shared decision making. If we build that into steps, the first step that you mentioned is a step that's skipped a lot. And if you skip the first step, there is no decision to be made by the patient, so there is no shared decision making. If the patient doesn't know there's a decision to be made, that there's options to choose from, and that their opinions are important, it's not going to work. And in rheumatology, as you all know, chronic disease, second step is in acute care not so important, but in chronic disease, the goals. What are your goals for treatment? Your goals might be very different from those of the clinician. So it's important for the clinician to find out what patient goals are. And it's important for patients to speak up and say what they think is important. Well, then we have, of course, laying out of options and the pros and cons, which is being done in practice. This is the step that's being done the most, but then not always balanced. Discussing the preferences and helping with deliberation of the patients. Patients don't always know what they want. You were very assertive and knowledgeable, but not all patients are. And many patients think the doctor knows best, so why is it up to them to decide? And then discuss the decision. And what I want to stress is who in the end takes the decision is not important for shared decision making. As long as the other steps have been gone through, and as long as the clinician has helped the patient, as long as the patient has voiced his or her preferences or goals, what's important. If in the end the patient says, you know, I don't want the responsibility for the decision, please doctor, you decide. If the doctor has gone through all the steps with the patient, the doctor can of course still give a recommendation and even make the decision. So this is not happening. We need a lot of work. We're going to discuss in subgroups, in round tables, how we can make this happen to a larger extent than it's happening now. And we need every help everywhere to get this going, because it's a big thing, I think. Patients need to be empowered, need tools and training, but doctors also need training and maybe need tools also. We're going to discuss that later. But also the system is not, generally you're not paid as a professional for long communicative consultations. In many countries you're paid for service. If you prescribe drugs, you get money. If you do things, you get money. If you talk for a long time and the patient says, okay, I don't want this new hip, bad for you as a doctor, you're not going to earn a lot. So the system needs changing. Maybe the consultations need to change, short, double ones with time in between to think about or to go to a tool. But we need first to train of both. We need all three, I think. Just a few slides on patient tools. Question prompt lists, you may have seen those patients coming in. You may, as your organization, have developed them for patients. What are the questions you can ask your doctor, and you can check them at home so you feel more empowered when you're in a consultation? Because generally you will feel often you'll feel disempowered. Many patients do so. So if you have a checklist to know which questions to ask, it helps. Option grids are on the table, examples of them. Maarten made beautiful laminated with the orange thing in the corner. It's just simply the columns are the options and the rows are the characteristics of the options. And you can even, with the doctor, fill out blank ones. Say, you know, I want to choose between these two treatments, but tell me about duration of treatment, modality, how, what the side effects are, etc., etc. Decision aids are increasingly important. Who knows decision aids? Who's ever accessed them? Is there anyone who's ever seen a decision aid? No. Well, decision aids are have been around for about 10, 15 years now, I think, but mostly in the US and Canada. And what they are is simply fancy internet-based brochures. And they help decision aid, they help you decide. So what they mostly include is, of course, information. There's information pages, usually they're internet-based, sometimes they're also just paper brochures or videos sometimes. But on the internet you can, for example, individualize chances that things happen by patients may plug in age and gender. But also nice about the internet is that you can have little tasks. For example, you can have a weighing scale on there and blocks with different weights. You can put a block on there. How important do you think this side effect is? And how important do you think this benefit is? And then the scale starts to move, and you can sort of start thinking through how important are these characteristics of the treatment to me. And it's a way of helping patients think what is important to them. Sometimes there's little videos of peers or letters from peers and coaching in the steps. What should you do to make a decision? What's important? How to find information? Where to go to find information? Many patients have no idea. They're passive. They don't know how to make such a decision and where to go to find information. And there's been 133 trials now and 3 Cochrane reviews, and they just work. They work in all these respects. Knowledge increases, patients have better expectations from treatment. People are taking photographs, but I understood that the slides will be made available afterwards. So okay. Oh, Twitter. Okay, sorry. Good. I'm not on Twitter, so that's very good. Decreased conflict, less undecided decisions, and better decisions better aligned with, and that's the most important one, I think, aligned with patient preferences. One thing is that they reduce certain types of interventions, so it's been used as an argument, shared decision-making and decision aids for cost containment. It's good if patients get the treatment they want, and if it's more conservative than the doctor, if you have in the US, for example, doctors that want to replace all these hips and knees, whereas the patients really don't want it, it's good if they get fewer hips and knees replaced. But it shouldn't be an argument for or against decision aids, I think, or against shared decision making, because it will not always be the case. I think it's an ethical imperative. A little bit increased duration of consultations. That's why I said we need to do something about organization of care as well. I don't have time to go through these, but when you get the slides, you can have a look at some of these rheumatology tools. And the Ottawa Health Research Institute has a beautiful inventory. You can just plug in any word and you'll find a decision aid for Most of them are in English, though. So before we go to the breakout, this was a very quick overview of shared decision-making, decision aids, other tools. We're going to discuss more of this in the breakout sessions. But maybe for now, are there any questions, remarks, comments, disagreements? Is this all new to most of you? Okay, so we'll see what happens in the subgroups. This is very interesting. What we're going to do now is we're going to have 3 tables. So the people who are at those tables, it's going to be a bit tight, I guess. Maarten is moderating that one, which still has a few places. It's being streamed. That one, the camera is going to stream that table. So if you're really opposed to being in view of the camera, maybe you should move to the other ones. But I like to have 10 people around each table. So if you don't mind being filmed, maybe you can go there and leave the other 2 tables for the others. And I was going to... what I was asked because of the film is, I should have said beforehand, maybe 1 table at the back for those who so that we don't have interference of all these groups. You can stay here, but maybe this group can go to the table more at the back so that there's not too many voices in the film. So I'd like to have 10 people at each table, and then we have 3 slides, and it says subgroup 1, subgroup 2, subgroup 3, but the idea is that all subgroups try and go through these questions as much as possible, and particularly in the end, maybe find if we can have some recommendations for EULAR how to carry this forward. So maybe first talk about your own country, and does it happen? What's the level of acceptance? Do people know about it? What happens in your countries? And then an important one, I think, is an inventory, that we at the end have an inventory of barriers and facilitators. It's on the sheets also that are on the table. And then what could the organizations in your country do to further this field? Oh, we have a 4th one, this one. So what would it be? What should it be? And then we'll spend half an hour on this till 5 till 12, and then we do plenary again. Any questions? You can also ask the moderator for the questions, but for now, okay. Good luck.
Okay. Welcome at this table. Very exciting because it's streamed for the first time for me. So it's quite exciting. Maybe good to start with just making around your name and maybe your country, where you come from.
I'm Dora from Iceland.
Yeah, thank you. Katarina.
From Bulgaria.
And my name is Maarten de Wit from the Netherlands. So I think we have a lot of different perspectives around the table. So that's hopefully a good input for stimulating the discussions. And I just propose that we start with the first question, which actually asks for what's the level of acceptance of shared decision making among patients in your country. And I just asked this to the group, and only a few of us indicated that they had some experience with their health professionals. But how do you assess this in your country? Is this an accepted concept, or is this rather new?
From patient's perspective.
From the patient perspective, from your perspective. Yeah. Who would like to start?
I think that people talk about it but don't actually put it into practice in a lot of cases. So I'm involved with a support group in Dublin, and a lot of people talk about how they want to speak to their doctor more and they want to ask those questions, but they don't feel competent to. So although it sounds good in theory, when they get in, they get overwhelmed, they don't know what they want to say, the doctor tells them this is a good idea, and they kind of submit to whatever the doctor suggests. And it's the lack of patient interaction sometimes. And it's also a fear of not wanting to switch from a rheumatologist or a doctor, any kind of doctor who isn't meeting those needs. People are afraid to switch doctors. And I would consider myself to be like trying to stay educated and that kind of thing, and it still took me a long time to switch doctors when the doctor that I was seeing wasn't meeting my needs. It's a hard thing to do.
Okay, so clearly you say that there's a clear desire among many patients for shared decisions, but in practice it seems quite difficult, and you mentioned some of the barriers.
I think all these people, so it's very difficult to change their mind, to change their ideas. But I think our organization have a plan to change this mentality, to change this idea by educating patients. I think that's the key.
Now,
to
I
change
also
all this.
have the feeling from I'm a doctor also, so sometimes I've offered shared decision making to the patients in Spain, and I have the feeling that if you offer them options, at least in my country, they're not used to this, and they think that you don't know. It's like, but it's the culture. They are not used to it. And even though they will not do what you tell them to do, because they want to take their own decisions, but they don't want to that way that you offer them options and say, you take it.
Okay, so this is interesting. So if a doctor wants to put shared decision making in practice,
Yeah, they look at me.
he is not seen as a competent doctor? Or
Not in my experience. I mean, of course, if this basis with high health literacy, they will understand, and we even have emails, like I did this last time. But not every patient is prepared for it. That's my impression.
I'd like to say in view of that first of all, maybe we need educating people what's decision making, exactly what this is, because I am also people in my country don't know what this is about. I mean that they don't know that they need to be involved in something like that, even they have the need, but they don't know how to do it and what is this, what's the benefit.
yeah. I think it's good to start with just also focusing specifically on the barriers. I mean, before looking for solutions, maybe first try to get a good picture. What are the exact barriers for putting shared decision making in practice? And I think you just say, actually you say there is a lack of education. There's no knowledge on shared decision. Is that only for patients?
And even the question, what's the level of acceptance? I could I don't know, have an input here of my experience and maybe of the hospital I'm going to, but I don't know. For example, is there been a survey on that? Do people know what this means in my country? This I don't know, so I wouldn't be able to answer to this. So maybe, I mean, at least in my
probably
country,
you can guess.
Yes, I can guess, but it would be good to launch a survey on this, and also afterwards to educate people on what decision making is and how to do it.
Yeah, yeah. Ofra.
May I add that this problem is part of the organization, the local organization, to have a job to educate and have workshops for patients. Learn how to be a patient is not so simple question. This is one aspect. And then you have to see, oh, the patient think the doctor was a god. Now he's not a god. You have to remind you what is your situation. You have to remind him if you are sensitive to something, and you have to discuss with him the options. Not to be afraid. Not to be afraid from the doctor. It's a session in educating patients. And I think this is one of the solutions that we come forward with in order to educate. But it's not suit everybody. We have to accept it. That about a third of the patients will not want to share disease. About.
Okay, what I notice is that we very quickly jump into the solutions, that we know what actually should do, but do we actually have a picture what the things are that are currently preventing us or preventing patients and doctors for starting shared decision making? It seems like it's logical to do it, but why does it not happen? Can we just...
But we had already two. Lack of understanding,
Yeah.
fear of the doctor.
Yeah.
And then
Doctor was
cultural.
God.
Yes.
Sorry?
The way they
Doctor
think.
was a god.
Yeah.
So don't interrupt God.
Yeah. So the perception of how
How you
you
should
have,
behave.
how you should behave. Yeah.
It's cultural.
Yeah.
Some kind of trust. We trust the doctor. Patient trust the doctor.
Trust
That he
is
will
ve-
know what to do. I don't have to bother myself about it. He will know.
So fear of responsibility in taking decision about your life. I mean, this
Sorry?
is sort of a fear of taking responsibility in taking a decision about your life and treatment, but it shouldn't be such a fear.
Especially if making that decision you have 15 minutes, maybe 10 minutes, and you're on, and they say here are 3 options or whatever else, and all of a sudden you have a tiny window in which to make a huge decision. And I know sometimes I feel like I go blank and I can't think of all the consequences, and I think sometimes patients feel that, do I have time to respond? Are they trying to get me out? Can I ask the questions? You know, so it can be a fear of having that small window to make a decision.
Time management.
So
It's
lack
time
of time.
So it's lack of time. Lack
during
of time.
consultation.
Lack of preparation.
And is that something that is a problem for the physician? Because physicians always say, well, actually we don't have time for this. Is this...
Yeah.
They
Is this
feel it
maybe
that
the
way.
patient
They say,
have to
I don't want the
prepare.
patient to speak because I will not have time for that. And we need to cover many things in this visit.
Yeah.
They are afraid of that.
Yeah. And I think you started also mentioning just there is an anxiety among patients just to bring forward the real questions that you have, even if you think the 10 minutes are already gone.
Yeah.
See his papers. You must be very brave to say, well, I still have 2 other questions.
I think it takes a lot of patient preparation to
This is the word.
I like when I first started with my new room, I sent him a letter of 30 questions, and I said I'd like to discuss these in our next meeting, and he kind of came in and he said, I see you have questions. It took a long time, and I said I'll give you a minute. And it worked. But that was my first meeting with him, and I was very nervous. But it's patient preparation as well. And sometimes I go and I'm prepared, and sometimes I go and I'm not. And I notice it's the times when I'm not prepared that I prioritize those questions, and the ones that I really wanted, I didn't get to ask maybe. So yeah, it's up to us too.
Yeah.
I think the question is, does being a patient is like being a client? Do you buy a dress in a boutique that you agree think it's the same. It's medical clientele. I think it's the same basic. You are a client of medical advice, and you need to be treated as a client.
And would be also being given specific advantages and disadvantages of each option. I mean, sometimes I was put a question, would you like that or that? And I wouldn't know what to answer because okay, can you explain, can you argue each point, what would be the benefits and the side effects or in my life, taking in account these that, for example, my goals, I need to be active, I need to go to work, so would this prevent me in any way? And of course, still there is no time to do that. I mean, for them.
Yeah.
Okay. Maarten, the point is that I really do not see what tools we can use to assess the shared decision process.
How to assess?
Yeah.
Maybe if you just went through the points that should be included in shared decision and you ask the patient, have you
But
been offered
are they
this?
actually implemented anywhere in Europe?
There are some, I don't know, you cannot give a general answer to that. There are some doctors who are quite good on this. And I know from one league, we got the example that they have established an award for the most communicable rheumatologist of the year.
Yeah, but that is
That?
communication.
Right? A specific, I think, Loreto said, it is a stepwise approach. So if you would like to make an assessment, you should actually go into the process and look, make a checklist, and is the doctor and the patient going through the different steps?
Yeah.
Then you get an impression of the level of actual implementation. And I think you gave the idea of a survey to explore the perceptions of patients about, to get an idea of the level. So that it might be interesting to do that on 2 levels.
We don't even have the terminology, in my country. I mean, in Romanian language,
Yeah.
it's not.
No.
Yeah, no.
And
I'm just
tango is for 2.
Yeah. I'm just aware.
Totally agree.
We just introduced each other. Maybe you can just say your name and where you come from.
My name is Sara. I'm from Italy for Association National Disease Rheumatic.
Okay. Yeah.
In Italy, for this problem, there are the tools for communication, patients and rheumatology. But in Italy is very problem. Association that the teacher, they can teach the patients for rheumatology use the time with the instruments. Now this problem.
Is that for developing
Also-
tools
also
or for
in-
implementing tools? Is that a problem?
The tool with the communication, with the meeting, patient association for teach the instruments in communication, the rheumatology.
Okay. So they don't allow the Italian league to play a role in. Do I understand you well?
This is together country national association in different country.
Okay. Yeah. Okay.
Maarten, correct me if I'm wrong,
Yeah.
but this is a volunteer process, right? This should be a volunteer process.
It
Because
works better
somehow-
if things are organized on a voluntary basis. Yeah.
Yeah, because somehow if this is like pushed
Yeah.
to be implemented as a mandatory process, then it's like all the pressure goes out of the doctor and goes to the patient. Because he needs to be.
Oh, you are there very right.
Yeah,
Because in
because
some places
many people say this might help. They are doctors here in practice, and they need. I pay my taxes, right?
Yes.
So
No,
So,
but
so this comes back to the mentality,
yes.
and I think
Of the patient.
yeah,
Not
well,
only.
not only,
not only.
it's the patient and the
And the
doctor,
doctors.
and I think the essential question is what you said. There is this culture of trust for the doctor, but it was also argued that sometimes this is a misleading trust, because does it mean that all patients are satisfied with their treatment and with their doctor?
No.
Whose body is
So it's on the, if you don't feel any going well.
There is a problem. You probably don't know that now they are pushing the doctors to take the shared decision making, but they are not training them to do them. So the shared decision making is you have this option, you decide.
yeah. You
It's your
decide.
problem.
Yeah, it's your problem. You decide. Yeah, exactly.
So-
Yeah, absolutely.
There is some
Yes,
for
the shared decision making, you have to communicate effectively, but they don't tell how to do it.
They just do not understand what
Yeah.
decision making.
They don't know what they have to deliver.
and they cut the time
For-
of the visit.
For
Yeah, and they
them,
cut the time of the visit. Exactly.
for them it's like this is telephone, this is pen. Which one you will choose?
Yeah.
And you're like, okay, I'll choose the pen. Okay,
Yeah.
done.
No.
This is for them. This is in their understanding.
They
I
even
try to
didn't
get a better
teach them
understanding
to
of
type.
what we have to change. So is this a lack of education of health professionals?
Yes.
Um,
Yes. In fact, it is very important for them to provide them evidence about how much shared decision making is going to save them time. They have the feeling that if they start with a shared decision model, they will need 30 minutes or 2 hours. But it's just the opposite. Showing
idea about what and there are you already gave some directions, and I would be interested to hear from you. It make you that I'm going to make this list of 30 questions.
I think it was that I was worried about the appointment coming up because I was very aware that it had taken 4 months to get the appointment and that I was going to have a short period of time and then I might not see the doctor again. And I kept saying to everybody all of my fears and all of my worries, and they were saying, oh yes, say that to the doctor. And it took, lots of people were talking about it, but and then I eventually said I'm going to have to write these down. So I made a list and I thought I'd bring them in with me, and then I thought, well, I'll never get them finished. So I wrote a very tactful letter that said, I know you're so busy and I don't want to take up too much of your time, so I thought I'd bring this up in advance. And I even categorized them into symptomatic and treatment related and alternative therapy related, and so that they would go faster. And then I posted it in, but it was also, he was a new doctor, and I was the youngest patient with the condition that I have, a very rare condition in Ireland anyway, and he, I don't think he was used to me, but once he got used to my style, it started to work, so it just took time. But
I think it's very powerful what you tell. It was an intrinsic motivation.
But it's hard to be I'm a secondary school teacher, so I talk all the time. So I got over that a long time ago. that it's being assertive. A lot of people feel a lot of fear to be assertive like that, to say, to feel, to trust ourselves. You said it's our body instinct, but it's hard to trust that sometimes. I will have extreme pain, and then I'll say, well, maybe other people would be able to handle this better. Maybe it's just me, and we try and downplay it sometimes, and then it makes it harder.
The new doctor.
A new doctor. My GP, they'd be willing to take me on because I know that I'm an unusual case, and would they be interested? And they called back and said, if you're willing to let us learn as we go along, you know, if you don't expect us to have all the answers. So I am lucky, yeah, they're great, and it doesn't matter who's in session on the day that I go, they're all willing to
Okay,
go with
this
me.
sounds so ways that I work on this.
The right doctors.
Some doctors I knew that.
So there are a number
Okay, for other options.
But share this.
we developed. There are.
I just click. No. Information. For rheumatologist. We don't. Book people communicate. Is important, is a difficult. Still is. In my dreams, patients teach doctors how to do this.
This is my nightmare. I totally, to be honest with you, I really think that this should be between you and your doctor. Whatever you decide, this you should do. To the patient, it should be in a relationship. If you want to make a shared decision process, we make it. If I want the doctor to make decisions for me, the doctor should make it.
I'm at the level of university because doctors are never trained on this. Yes,
They train them, but there should be an option.
No, they don't train them.
Fine.
In Tel Aviv University Medical School, they insert a course, obligatory course, how to listen to it. Because patient that also has house, husband, children, and then it's the first step to understand. Okay, you need a solution. We will talk about it. We will speak. We will come up. I have a paper about it because when I was pregnant with my eldest son, he is now 20. My doctor said I need either to eat dirty yogurt with something, I have also Crohn's disease, or I have to take 5 milligram prednisone all over the pregnancy. And we discussed these opportunities. And finally, to make it short, I decided that I want to eat regular food, so I will take prednisone and so on. But it was a dialogue. And this means that that doctor, marvelous doctor, agreed to accept my decision if it's not his first priority for my treatment.
This is what I'm talking about. It's a relationship.
Yeah. But I think it's also, we also notice that there is this culture mentality, and what you suggest, and preferably things are changed in good harmony and in partnership.
There is this option should not be pushed. It should be, but again are there, but it's we are over.
Now, you what decision making? It depends on the doctor.
I'm happy with my doctor. Sometimes I give the decision to her. Sometimes we discuss. It depends on the case. Why I go there, for what reason. It depends. If I'm not, let's say, confident that I know.
But you have never experienced that you would like to become more involved in, while that was not allowed by your physician. You have organized extrinsic motivation and to time for that patients and to listen to that patient, and a little bit less, but to complement their view that not only the disease but also the patient who disease. And so if there is somebody else, a organization of professionals who say you should be do better, you
I like. I mean, I and go to their jobs, but it was if you are
of
youth and a ceremony,
very useful. Agora, the organization for southern countries for patients with RMDs, built a project on partners in treatment, it is called. So we were keen on developing some tools for enhancing communication between patients and doctors. So two sort of tools came out, and also some of the questions and preparatory steps, what to do for the first appointment and for the and some two sets of cards. One are for patients and the other are for doctors, but it's very, very important that they are built in the same way. I mean, there are 4 steps, and also the patients and the doctors can follow exactly the same steps and have, of course, different questions, and also they are set on the goals, which is very, very, very good. So these can lead to of course it concentrates more on communication. I mean, the idea of communicating, but it can be adapted and put shared decision there. Yeah, and
Communicate.
Yes, everything.
I'm aware of the time.
Yeah.
I think this is something exists like she described on Iceland. Would it be helpful? Yeah. So I think maybe EULAR should also think about, there are materials and ideas and
we are translated these cards.
okay.
the other
To
language.
Greek.
To Greek and Spanish and
Okay.
language.
Yeah, good. Okay, is there anything that you urgently want to put on the agenda now before we stop this group discussion?
Just a quick comment, maybe.
Yeah.
I know this, but this is from my experience, that being willing to get involved in PARE, in my organization, this enhanced my doctors and physicians' trust in me, and they are more open to hear me and to be involved in the decision-making process. So this I meditate for, encourage people to get involved, because doctors are more open and they see us as, trained and yes, indeed.
So actually you say we as patients can be role models that stimulate doctors to make a change.
Yeah.
If they see that it also has benefits to have well-informed patients in their clinical room, I think it becomes
Sometimes imagine a doctor that the patient that enters said, doctor, I read in the internet that there is such and such and
Internet is a taboo.
and so. Patient should be so. The doctor is over. First of all,
Isn't that not a great starter of the dialogue with your doctor?
It's a bad situation for the doctor, and they have to overcome the situation. They said, listen, I am your doctor, I know your position, I know everything with you, tests and everything. Let's talk together about what is your situation.
Okay.
It's good, but it's also about problem.
Yes.
If you come
Yes.
like this, okay, it's not good, but maybe if you say, okay, I heard about, I don't know if it's good, but I think,
Yes.
I think it's
that
more,
changes.
yeah.
It's a bit of
I
problem.
think we can discuss for 1 hour further about the role and the value of internet.
And the internet is another, but it's a
That is-
threat. It's a threat for
yeah.
patients.
Yeah.
Sometimes people phone. I read it's a very bad situation.
Yeah, but it's
Check
two
with your
ways.
doctor.
It's two ways. I think
Yes,
it's what
of course.
Anna said. It can
So, side. So, the internet information in the website of the organization is very big purpose.
So we also have one thing that we recommend here. Good. Thank you all for your really active participation in this breakout session.
Important. Thank you very much, Maarten. Who is the secretary in this?
Secretary of
Agora, who is she?
it's not here. She's not here.
Okay, because Israel is
Okay, people, we're wrapping up. Maybe if the people from the back can come up a bit closer. We're running out of time. I would like to, we have 3 subgroups and each subgroup has someone to report from the subgroups. Maybe we should use microphones because the room is so big. Maybe we start with Theodora. Yeah, you want to go up? I don't know if you need a mic. Stand behind the catheter with the mic. Okay. Yeah. The room is too big for. In the other rooms, we could do it without microphones, but. And what I'd like to do is make an inventory, and then the next groups just add, for time's sake, just add the new things.
We're just decision making together, doctors and patients, taking into account of the patient's preferences, giving a perspective of the patient and choosing on a treatment. So in my table, there were 9 countries. So only one country, the Netherlands, had experience about the shared decision making with the doctors. So they
and
talked to us.
Ireland a little bit too, I think.
Yes, but the Netherlands has
a little bit
okay.
too.
So he can share the decision with the patient, and they choose the treatment, and they have a special training, so they both have an opinion. So in Ireland, as the Irish told us, they give information to patients with booklets and like loose leaf or something, and the situation is improving. So it matters the self-education and the health literacy of the patient. We should take it into consideration. It's very important. It's a key role, I think. So they can share some key points to the doctors and then discuss about it. Because it's very important, the understanding of your health problem and the consequences of your treatment, and to have some accurate information. So there are some barriers, many barriers.
Yeah.
So one of them, the most important, is the consultation time is limited.
I was going to say, we have barriers on the side of the organization and the doctor. Maarten, are you going to do those? And I do the barriers on the side of the patient? Is that okay? Okay, you do the patients, I do the system, okay, and the doctor. Okay,
So
time.
We have the consultation time, which is very limited. The patients are they're being passive, they're just listening. So we deal with the fear of, they're intimidated by the doctor, the fear of to speak up and to express their opinion. The lack of communication between the doctor and the patient. We have also, from the perspective of the patients, the fear of responsibility. Because let me tell you, it's a very, choosing a treatment, considering a chronic illness, it's very important. It's a key role, I believe. So we just need, among other things, a patient's advocate. It can be a representative from a patient organization to give a choice to patients and informative position about their rights, their options, their taking into consideration opinions. And, well, the doctors might feel threatened.
Yeah.
But, yeah. What I found very interesting was they asked the 3 most important questions campaign.
Yeah.
So it started in Australia and continues in UK. And the most important question we should ask the doctors are, what are my options? What are my benefits and harms from my treatment? And what does it mean? What does it mean to me? So, we need more empowered patients. We need more informed patients. And we need doctors with communication skills, and which do not speak very much with terminology, so that everybody, and we do the most beneficial thing for us.
Okay.
And that's all.
Thank you very much. Already. We've been writing about barriers. I wrote down the patient advocate buddy solution already. Other groups can, looking at the barriers, here, the group here, do you have any barriers to add that you, on the side of the patient or the clinician or the system? Who's you reporting for you? Do you want a microphone?
One barrier would be the attitude among patients about the doctors should know best. And there are great variations in preference, of course. And in some countries, patients need to be qualified in order to be invited to shared decision making. That means they don't have to be doctors, but maybe professionals like lawyers and engineers, or they are not worthy of shared decision making. And there is also a barrier among patients that they will not understand the information they get, so they fear shared decision making for that reason. And then among clinicians, there might be an attitude that patients should not be burdened with a whole lot of information. And time constraints we have heard about. And we also heard the view from one country is that doctors sometimes have more shared decision making pharmaceutical industry than with patients, which is another barrier. And the narrow medical perspective, of course, is a barrier to shared decision making, and no real communication taking place, although the
I go later.
For not being how could we say that? Not want to argue. You don't argue with your doctor, and he knows best. He knows best.
Yeah.
But we think sometimes that it is more the outside perception of trust available. But actually, one of the others said later on, what is more important for me was the trust that I have in myself. So maybe that was, I think, a powerful statement. There is also anxiety among patients, lack of preparations, and a lack of information given about the pros and cons of treatments. And on the side of physicians, we had also mentality. There are cultural issues, lack of time mentioned, lack of education. Did I forget anything?
Is it lack of education or lack of awareness? I mean, education in the sense of communication skills, or that they don't even know it exists and it's possible? Or?
What I believe it was really the skills, because it is in many countries less,
okay,
but they don't know how to do it. That is the problem. Is that correct? Yeah.
That was our group also said one issue for EULAR. What can EULAR do? EULAR can take care that doctors are trained in these communication skills, I think. Yeah. Thank you. Now, if we have a whole long list of barriers on the side of the patient or the system and the doctor. Theodora already mentioned the patient representative or the body going along with the patient to the consultation. Any other solutions or suggestions that the groups propose PARE or EULAR to take on? What are the things you all go home? Is there anything you take home to think, well, my organization could do this or that, or I'm going to send an email to EULAR to do this or that, or I'm going to go to my rheumatologist and tell him to do this or that. Did you discuss these things? Yes, your group did?
I thought we need a recommendation from EULAR so we can cooperate with the doctor association and suggest such a training for doctors.
So EULAR should endorse make a statement that this is important so that your local organizations have more power these trainings. Is that what you mean? Yeah. Yeah. If EULAR says it's important, they will be listened to more than when PARE says it's important. Other views on this? What can you do when you go home? Is there anything you feel you can do, or is there anything you need to do something with your patient organization?
We had two examples. Maybe that could be set up a survey just to explore the level of implementation and awareness of shared decision making. So that could be a starting point. And there were several suggestions of developing a kind of diary or a dossier that you can use when you visit your doctor. And we know that there are already some tools so that you can better prepare for your consultation. And this should be
shared. We had two people in our group, one from Belgium and the three Irish ladies who said that they are there, but there were problems with them. I don't know, from Belgium, they are there, but they're not used, that they don't work.
We are going to our doctor 2 times in a year, and we are coming there with our book. They have no time for everything that has passed in the 6 months. So the Rheuma passport is not very used at this moment for the patients.
You were not 100% positive either?
Arthritis Ireland have the books, but the patients aren't always aware that they're available. So they're just sort of guides to help the patient keep records, and then they can shorten it for a few points when they meet the doctor.
But the patients are unaware that they exist, but if
yes,
patients use them, they work?
Well, we've no feedback on that. We issue them to the patients, and you know, the ones that use us have told us, but we know official figures, but everybody isn't aware of it. It's only patients that contact us through the helpline or, you know, to Arthritis Ireland.
So I think from these two, we cannot conclude that they don't work. I think we have to take care that the patients make a succinct, a short, not too long report to the doctor, otherwise it's going to backfire. And patients need to know that it exists. Those are two important messages, I think. Yes, here?
In the Netherlands, we have developed, for instance, a booklet for rheumatoid arthritis. We are busy with bringing it all over the Netherlands. What we see is that it especially helps young people or older people who just have discovered they have rheumatoid arthritis. Then for them it is very important to have it.
Yeah, so particularly for newly diagnosed, it's very important. Yes, Christina?
It was discussed here at our table that you might have to start at a much more basic level in several countries, because first you have to inform about the rights of shared decision making, and then maybe you have to provide examples of how it can be done. So that is more basic than starting with each patient to raise awareness about the rights and how to do it.
And among doctors?
No, among patients. Yeah, among patients. Care for visits. Things like information and awareness first, and then more hands-on. I would also like to now that I have the microphone. Yeah. Here it seems that in those countries who have patient partners, they are very important in helping to raise the awareness about, among medical students. But many of the members around our table in their countries. So is there anything PARE could do to spread that concept? I know the pharmaceutical industry can help.
Agree with, of course.
Our group give patients conferences, apology conferences, one depending, of course, on your. It may be less intimidating, but that it's a good way to educate, like Maarten says, to educate professionals about the patient perspective. For them also, for many professionals, it's very new to learn about the patient perspective. So if you can go to your rheumatology associations of the doctors and see if you can get invited to their meetings in a special session, maybe at the end of the day with drinks or whatever, and just bridge this gap between doctors and patients. Yes?
Since it's an issue that belongs to all fields of medicine, we can be the first in the world to have a coalition of health organizations to spread the news to everybody, and with the coalition of patients to convince the Minister of Health for resources and so on, because it really belongs to every doctor-patient relationship. That's the matter of field.
Yeah, so we as a group have the ability to, as a coalition, to create awareness, public awareness, awareness in policy, public policy ministers, that there is such a thing as shared decision making and that patients are entitled to it. That's what you meant? Yeah. For the time's sake, we have a few more minutes. Is there anything particular that you would like to prioritize? What should PARE take as a home message, or what should be the message to EULAR? Yes?
Just would like to hear
Yeah, the 3 questions was a study in Australia that showed that if patients ask these 3 questions, they get a more shared consultation. Originally, they were, what are my options? What are the pros and the cons of these options, the benefits and harms of these options, and what are the probabilities of these benefits and harms? The last question was far too difficult for patients and for many doctors also. So they changed, and it depends a bit on which country you take. The Netherlands is using it, UK is using it. Normally the last question is more like, what does it mean to me? But there's also people that use the last question, what do I need to make a good decision for myself? But the important thing is, what are my options and what are the pros and cons of these options, and what does it mean to my daily life? I think that's the take-home one. And what I would like to stress is, I try to prevent people from just hanging up all these posters and sending out brochures to people to ask these questions without getting your doctors along. Because if you have patients going to the doctors all of a sudden asking all these questions and doctors are unprepared, it's not going to work. Doctors will become defensive, at least many doctors will become defensive and will hate it, and it will backfire. So if you do a campaign like that, also involve your doctors, that this is happening and that patients might be more speaking up more than they are expected, and they should be prepared for this, and that it is a good thing, of course.
I think that was also clearly raised in our, that whatever you do, it should be preferably in collaboration and dialogue and in partnership with the health professionals.
Yeah.
And I think that's also the way that EULAR and PARE wants to work.
Yeah. So key messages, anyone who has the final, what should we tell EULAR? What should PARE do? Or priorities among this list? I mean, we have the buddies, or the patient, go along patients. survey. I noted email consultations just as something that hasn't been mentioned, but that was mentioned in our group as a solution, maybe for all the time problems. But your national system that's starting now in the Netherlands. And we have these talking to doctors at conferences, and particularly the patient diary booklet thing. There could be, of course, a basic format that all the national patient organization countries, maybe with a caveat, the do's and don'ts, so that it does work. Do you, yes?
We are talking about options, but for example, I would very much consult with my doctor, let's say, and so that patients, when they build something, I don't know, a tool or some materials or anything, they should consult with doctors, because I would ask him, I would go and ask, okay, I've learned about shared decision-making process. I'm sure you are willing to implement this and communicate with me, but what can I do to help you do that? So if he is willing, I mean, he says, okay, I want, and this is what you can do, this means that he would implement it and he would do it. So whatever we do, we should consult. Yes.
And do you mean at the individual level, you and your doctor, or do you mean at the group level, maybe at a meeting?
At the group level, but I just gave an example of just to simplify. But yes, at the group level. And for also as personal level, I noticed that if somehow I managed to, I don't know, be in touch with my doctor, but not in his office, and on common ground, let's say, he is more open, and that would be the time when to raise problems like, I mean, something like that. Yeah. But this is on.
Okay, thank you very much. Any final pressing, urgent matters? No? Okay.
I think you have been a great audience.
Yes, thank you very much. We've had two workshops and they've been very, very different.
Yeah.
This was nice because we had, it's a bigger group, and we have many more nationalities, many more different countries, which is, I think that's fantastic about this meeting.
Yeah.
We've had a lot of input.
Yeah.
We're going to report back. PARE is going to report back.
We will. What we will report back will not be a shared decision.
Oh.
Which means that you might be surprised after the coffee break what you will see, but hopefully you will recognize some of the things that has been discussed here. I would like to end the session by saying thank you to Anna. I think it was great. Yeah. And indeed, I agree that EULAR really provides a great opportunity to get experts from outside rheumatology to share their experience, and I think it's our responsibility also to make it work within the field of rheumatology. So thank you for that. Christina, thank you for leading one of the subgroups. And then I would like to say, well, I think it's a coffee break now.
It's refreshments in Tara 2, outside the plenary room.
Okay.
And promptly back at 1 o'clock. So back at 5 till 1.
Yeah, so and then we will continue with the plenary feedback session like you have also seen yesterday. Okay, thank you for being here.
Thank you very much.
See you later.
to make to the actual show reel, but we can't do that until
Okay.
they're going to have to load
So
it on this laptop.
is this workshop 6 that there is done?
No, they haven't had a look at it yet. I've just got it up ready for them. Thank you very much.
Ik ga die zelfmanagement... Ik ga de zelfmanagement eruit gooien, is dat oké? Ik dacht dat we dat al gedaan hadden, ja. We hadden self-management eruit gegooid. We didn't do self-management, so I wanted to...
Je sample eruit halen.
Sample? Oh, yeah.
We can agree
I don't know what
or
happened. We had
reformulate.
efforts. Oh, patient elmation. That's the same, the first and the second one. Should we do the second one? It's nicer, maybe, because then we have SDM in there and for the doctors also. Do we need only? Are we allowed only one?
No,
two.
we can have 2 or 3.
Or maximum 3.
Because doctors should.
Yes.
And then the collaboration. But we have to have something that they vote against because this is too nice.
Patients should not be involved in decision making because
We speak about health professionals.
Oh, sorry. Yeah. Should be aware.
Should be more aware.
Misschien moeten we het harder
the value.
doen. Dat zou helpen. Maar everybody will be in favor of that.
Yes.
Should be made aware. With great
We
force.
cannot, if you want something to vote against, we cannot expect health professionals to do it. It should come from the patients. Or are these the statements that we're going to give to you? Is it meant to raise discussion, these statements?
Patients should become more articulate. Or het is misschien wel leuk om maybe it's good to make it more controversial.
Yeah, I would say I have a one.
Who should take the initiative?
No,
Yeah,
it's for the patient. Then
Because
maybe
this
we
is
get
such
some
a
red
no.
cards.
This is such a
no-brainer.
Yeah.
Is it really?
This
Up
one,
to
this
the
one.
pa-
No,
oh,
no,
yeah,
yours.
yeah.
This one is a no-brainer. Where's the
Yeah.
insert button?
It's up to the
Yeah, but
patients.
it's also a call for action. If there's a large majority
It's up to the
vote,
patients to make shared
Shared
decision
decision
making.
making happen.
Oh, come on.
and patients multiple or single.
Huh?
What do we mean?
No, it's multiple. When we're both individual patients and patient representatives, no? It's up to patients, up to the patient.
Do we mean
Rather than health
individual?
professionals.
Do we? What did you have in mind? Patient organizations?
Both, I would
Individual?
say. I would say this means that you can't expect healthcare to take the initiative here, but it should be by patients. And that's a little bit.
Yeah.
And can we
Could
do
be
something
read
with the
in-
collaboration without making it a no-brainer?
Patients to make shared decision making happen. So if there is
We
a
can have debate.
balance, you can conclude and say one sentence about the importance of collaboration.
Yeah, we can